Uh, we have had a introduction to these topics yesterday during one of our own department meetings with the help of our critical care team. And Dr. Darcy covered some of the features which I hope would act as an introduction to your topic about, I'd say, essential conversations, because the lessons learned have everything to do with being a doctor and not simply with end-of-life decisions, but they're present in everything we do. So couldn't think of a more important conversation. I want to thank you. Could you introduce yourself a little bit to everyone as well? Thank
Sure.
you.
You can hear me okay, Dr. Dempsey?
Yes, we can hear you fine.
Perfect. Welcome.
Welcome. Microphone's on.
Great. Thank you for welcoming me, and I'm happy to follow.
I can't hear you.
Oh, you can't hear me.
Hang on, Toby. Let's see. Let me. I can hear you just fine. Dr. Dempsey, can you hear me? Let's see.
There we go. There we go.
Now you can hear me now. Okay.
Very good. Thank you.
You can hear me?
Yep.
Great.
Good.
Good. All right.
Thank you all for having me, and I'm happy to follow on the heels of Dr. Darcy, someone for whom I have great regard and respect. I am a medical oncologist, a thoracic oncologist here at the UW. I also trained in palliative care and direct the palliative care program here. For about 7 years, I directed our fellowship training program, which is one of the largest training programs in the country. We have 4 fellows every year. The palliative care program has established itself in a number of different ways and has won some awards over the time period that I've been here, and our development has been something that I'm really proud of. Today, I don't intend to talk too much, as you alluded to, Dr. Dempsey, about palliative care, although at Than's request, I'm going to do a brief introduction on palliative care and how I think about it. I will preface these comments by saying that when I interact in particular with neurosurgery, it is most commonly around end-of-life care. The truth is that that's a very small part of our clinical practice, providing care for people at the very end of life. It happens to be the space where we interact, so it wouldn't surprise me in the least if that's your association with palliative care, which is at the very end of life. The truth is that that's an important piece of our practice, but not perhaps the most intellectually challenging or interesting. We very much like to work with people who are facing serious illness, but have lots of living left to do. And then we are in a position to help them understand their illness, help them cope with their illness, help their family come to terms with it, but help them squeeze out as much good living as we can. And that's a much more satisfying aspect of our clinical practice. My research, as this conversation is titled, is in designing what I think of as designing conversations, and we will dive into this and I will tell you a lot more. And I think much of it, hopefully you will find applicable to your lives. So a few disclosures. I don't have any financial disclosures. I'm a thoracic medical oncologist and a palliative care doc. I find that I cannot simultaneously practice both palliative care and medical oncology at the same time. There's enough of a difference between what you're doing when you're practicing palliative care and when you're an oncologist that it's a struggle for me to do them simultaneously. In fact, I can't do it. My work in design tries to bridge from different places to what I've learned about communication from palliative care. We've done studies with nephrologists around dialysis decision-making, with acute care surgeons around surgical decision-making, with oncologists around clinical trial decision-making, and the stories go on. I've bridged to a lot of different places, really just bringing communication from palliative care. And then another is just a disclosure, which is that the impact of communication interventions is hard to measure. Our understanding of how to measure these effects is limited. And the truth is I don't have all the answers, but I will give you the best information that I have. A few acknowledgements. I like to lead with these because the people that I work with are really important. In particular, we have a collaborative called the Athena Project, which includes Bill Ehlenbach from Critical Care, Chris Queckaboom from the School of Nursing, Gretchen Schwarzy from Vascular Surgery, and Amy Zielinski, who is the Director of Medical Education in the Department of Medicine. I work with a group that's now called Delve. Actually, they've changed their name, a design firm here in Madison and San Francisco. I have a number of wonderful colleagues in palliative care. And then we've received funding from a number of different sources, including the NIH, as well as some foundations. And I also want to thank the Ellen and Peter O. Johnson Chair in Palliative Care, which is a chair that I hold. So briefly, what is palliative care? Here it is in words. Specialized medical care for people with serious illness. Serious because it doesn't need to be end-of-life care, just something serious. Might even be a curable disease. Like we do a fair amount of work with, for example, bone marrow transplant in particular, sometimes transplant. It focuses on providing patients with a relief from whatever is bothering them from this serious illness, regardless of the stage. Our goal is to improve quality of life, and it's really appropriate for anyone at any age and at any stage, as long as the disease is serious. We like to work with whoever is normally taking care of you or your patient. Another way of thinking about palliative care, the core components of our work certainly includes care of the dying, but also advanced care planning, getting people ready for what's coming. Coping is a large piece of the work that we do, and palliative care interventions have shown a number of benefits, and our field is coming to believe increasingly that helping people cope is perhaps the lever that brings about the most benefit. Communication is an important skill set, symptom management, and also psychosocial support for both patient and family. And then the final way I will think about this with you is in the form of metaphor. I want for you to imagine that you are standing on the corner of West Wash and Broome Street, and a Japanese tourist approaches you and says, "Hey, what's the name of this block here with the Indian restaurant?" And you say, "I'm not sure what you're asking. That's West Wash and that's Broome Street, and over there is Mifflin and Henry. The block is just the empty space in between the streets." Now, the tourist might walk away confused. And so to understand that, I will transport you to where my brother now used to live in Akita Prefecture, Japan. He was teaching English there for about 5 years. And this is literally where he lived. This is his block. So let's imagine that you're looking for my brother's apartment, and you approach someone on the street and you ask, "Hey, what's the name of this street?" They might say, "Well, I'm not sure what you're asking. That's block 14 and that's block 13. And you see, in Japan, blocks are named and streets are just the empty space in between the blocks. And when my brother was explaining this to me, it really got me thinking that we here in the United States and in many parts of the world look at a piece of visual data and we see streets. But someone who grew up in Japan looks at that same piece of visual data and sees blocks. And that got me thinking about medicine and how that might translate to medicine. And I thought, and I did these last night for you all. I am not a neurosurgeon, obviously. I just made some guesses here, but diseases that you all treat, like glioblastoma or subdurals or adenomas, we tend to think of medicine in a streets-based model where we've got diseases and we've got treatments, and we apply certain treatments for certain diseases. So palliative care is more of a block-based system. So in those moments where you are sitting down to have a metaphorical cup of coffee and asking people what they hope for, what they worry about, and then you use that information to navigate the streets, in this case, the treatments, then you're practicing palliative care. And so I suspect all of you practice palliative care all of the time. I just want to give you a name for those moments when you're doing it. When you're asking yourself and your patients those sorts of questions, when you're asking about what matters, and then you're modifying your treatment approach based on what you learn, you're practicing what we would call primary palliative care. We would call either primary or tertiary palliative care or generalist or specialist palliative care. So when you're consulting palliative care, you're getting specialist palliative care. When you're doing it, we call it generalist palliative care or primary palliative care. And I suspect you practice it all the time. Now I'm going to drift towards design. So I'm leaving behind my what is palliative care portion. And I'm happy, by the way, to take questions. I can't see the chat or the Q&A until after I've stopped sharing my screen. But if you put questions in there, I will do my very best to answer them.
Toby, just so you know, I'm monitoring that. So if people bring up questions, I can feed them to you.
Perfect. Yeah, I'm happy to take questions. So I want to talk about designed conversations. So think about conversations that are important, that you get one opportunity to conduct, and that you need to get right. You have lots of these conversations. I know you do. And I'm sure that you've thought about them and that you have ways in which you approach, for example, informed consent or a decision-making conversation prior to craniotomy or any procedure that you perform. So those are the sorts of conversations that are really important that you get one opportunity to have with a particular patient and you need to get right. So those are conversations that are ripe for design. I'm going to tell you about some of the conversations that I've worked on designing. And from that, you'll be able to, I think, translate pretty quickly to your world. And I would love to hear about the conversations that you have in your life that are really important. To make a quick distinction, this is the difference between a conversation and a lecture. I'm very much talking about a conversation. This means that it's an exchange of information between two or more people. It means that I don't have complete control over the way this unfolds, that the other party in the conversation has an important role to play and will alter the way in which the conversation unfolds and will alter the outcome. It's different, obviously, than a lecture. In particular, here I am in my office. Than can jump in, but you all have relatively limited opportunity to no opportunity to interrupt me or to change things. I've prepared this so that I pretty much have control over how it's going to unfold. That's obviously very different than a conversation. And so we are talking about conversations. I want to touch on, this is Viola Spolin. Viola Spolin is the mother of improvisational theater. Her book called Improvisation for the Theater, written in 1963, remains the gold standard text, really, for people who study and teach improv. And she had 6 fundamental domains. They were close listening, taking the perspective of another, recognizing, reading and responding to emotion, learning to mirror, being spontaneous in your responses, and being present. I have taken a couple of different classes, actually got credit for one class here at the UW on improvisational theater. And I can tell you that it is one of the most powerful techniques that I have used to further develop my conversational communication skills. Because it asks you to do all of these things, which turn out to be really important when you're in a dialogue with someone. And it also turns out to be that to teach someone new communication skills, it's almost impossible. I'm going to give you several tools over the course of this lecture, but the truth is it may feel like you'll be able to turn around and use them the next moment, but odds are you probably can't. You have to drop yourself into practice. You might do it in a simulated setting like we do when we're training people with improvised actors. You might do it in real clinical work, but it has to be with great intention that you're going to be practicing something. And improv is one of the techniques that we use to help people learn new communication skills. The other kind of architectural point I want to make is that as clinicians, we tend to see people either really close, maybe that's like a biopsy result or a lab result where people are really close to us, so they're hard to be in focus, or they're moving really fast past us. You know, we're seeing them for 5 minutes on rounds or for 15 minutes in a clinic visit. And so what happens is that patients often are blurred because they're either too close or too far away. And shared decision-making, which is where I spend the bulk of my time, I focus on shared decision-making conversations as the conversations that I like to design. An opportunity to do good shared decision-making is an opportunity to stop the blur, to slow people down for a few minutes so that they are in focus and they are in clear reveal for you to spend some time with them and make the right decision for that particular patient. So it's important to recognize that I'm not trying to change all aspects of our lives, just those moments where we are facing an important conversation, one of these conversations that we know we've got to get right. So here we go, design conversations for people who take care of other people with serious illness, which is you. My goal always is to provide the best care possible. So as an oncologist, the tools that I have at my disposal personally are chemotherapy, and I work closely with surgical and radiation colleagues. Patients commonly come in through a medical oncology input, and then it is up to us to determine who else they need to see and make appropriate referrals. So chemo, radiation, and surgery are tools at my disposal, but also best supportive care alone, with or without chemotherapy or other cancer therapies, or what we might call observation or surveillance. These are the most common tools that are at my disposal. When, as a clinician, you think of yourself as providing the best care possible, you'll realize that you have many more tools at your disposal. If you think of yourself as someone who performs craniotomies, then you've limited yourself to a lesser tool set. So I would encourage you to move up and think of yourselves, move up to a higher level and think of yourselves as providing the best care possible. And many times that will involve surgical intervention, but sometimes it won't. And it allows you space to say to the patient, my goal is to provide you with the best care possible. And in this circumstance, the best care possible actually is not surgery and is, X, Y, or Z. So when you've created that frame for yourself, you may come to realize that you have many more tools at your disposal. And I want you all to be able to be as nimble as possible. So here are some of the tools that I'm going to talk about today. And I'm just going to go through them in turn. It's going to be fun. So the first is to think about time. Now, this is coming from the perspective of an oncologist, and you'll have to translate this a bit to yourselves. But I see people in discrete snippets, maybe an hour visit for a new patient, maybe 15, 20, 30, or 40 minutes. I have appointments of all those time slots, depending upon the circumstances. But I see people in discrete moments. And the reality is that most of the time, they're not in my office. Most of their time, they're at home, they're outside of my office. And it's also important to realize that over time, I might see them 8 times for 30 minutes each, but I have 4 hours of face-to-face time. We as clinicians tend to think of those visits as discrete and standalone interactions. But the reality is I have 4 hours and I need to decide how I'm going to spend that 4 hours. There's some information that's necessary and important for me to bring up early. There's other information that's necessary and important for me to bring up in the middle and maybe late. But I can consider what information I want to bring up when. And that helps me to design actually more than one conversation. And I'm going to touch on that, but conceptually, this is important to me. So because I make decisions before, the 6th visit with a patient, I'm making decisions on the 1st visit. I'm not going to bring this information up now. I'm going to wait until visit 4 to bring that up. And architecturally in oncology, that works quite well because I'm seeing patients, every 3 weeks for chemotherapy, and there's a decent amount of predictability to it. They're going to have scans, for example, prior to their 3rd cycle of chemotherapy. And I know on a scan day, they're either going to get good news or bad news. And I can anticipate I will have contingency planning for good news and bad news. But I know that visit's coming. I know that it has prognostic significance, and I can save some information that I want that is important that I'm going to bring up on that visit. So just an example from my life, but I think probably applies to yours as well. If you give yourself the flexibility to think about your relationship with them over time. Let me just tell you a little bit about my research. So I study conversations, and one of the ways in which we do that is we have transcribed audio recordings of conversations. And one of our studies, I'm just going to go through briefly, we analyzed the talk in the cancer clinic, and we had a variety of data from cancer centers across the country. We had mostly academic centers, but we also had a couple of private practice oncology clinics. And we were able to discover that the talk in the cancer clinic is remarkably consistent, regardless of where in the country you practice and regardless of what type of practice you are. Oncologists talk about symptoms. Oh, I should say that we analyzed scan result conversations because we were interested in conversations that had prognostic significance. And so whenever a cancer patient has a CAT scan, there's prognostic significance, either good or bad. So those were the visits that we only listened to those visits. In those visits, oncologists talk about symptoms, and then they talk about scans, and then they talk about treatment. Interestingly, we had hypothesized that there would be space in there where they would talk about prognostic information or life expectancy explicitly, or other things related to the seriousness of the disease. And the reality is that we had almost no examples of that in our data set. So one of our, and scans, I should say, there's 3 kinds of news. Oncologists either have good news or bad news, or they have stability, which we call good news because the cancer is not growing. Our I'm going to show you a little bit about how kind of we make conclusions. So this is from one of our papers. So for example, when good news is discussed, it's largely just exposed, and it's exposed very quickly. The patient in this case aligns really well with what the oncologist is saying and agrees. The prosody, which are some of those micro inflections and features of speech, so the prosody is upbeat, it's good news. As opposed to downgoing prosody, it's bad news. And then usually continued treatment follows. We described a few things that hadn't been described in the literature before. We called them laudable event proposals and appreciation sequences and other kind of conversation microscopic levels of conversation that from a nerd perspective I find really interesting, but I don't think, unless you all are curious, we can talk about later. Here's what our data look like. We use something called conversation analysis. Conversation analysis, just to give you some sense, takes anywhere from 10 to 100 times the length of the audio to transcribe. So if you have 10 minutes of audio, it can take you anywhere from an hour to 10 hours to transcribe that 10 minutes. Of course, you hire undergrads or graduate students to do this for you, but this is what it looks like. You see encoded on the left the CA transcript, and it encodes like this. For example, the 0.9, that's a pause, a micro pause, 0.9 seconds of a micro pause in between the doctor's statements. The colon in between the word fine is a small pause, so that means that the word fine was drawn out. I'm fine. And then the arrow means the upgoing prosody. So I'm fine, thank you. Your CAT scan looks good. So this is what it looks like. This is what all of our transcripts looks like. I'm not going to show you the CA transcripts anymore after this because it's a little hard to read, but just so that you have an example of how we do these analyses. Oncologists deliver good news, which again is revealed. So I'm fine, thank you. Your CAT scan looks good. So that's an example of this, the prosody going up and the CAT scan being revealed right away. And then there's this alignment, right, where the patient's like, whew, and the patient says, good, which is a good thing, very good. It's a very good thing. Yeah. So there's this alignment that happens right away. Stable news is very different. Stable news, oncologists, you can see, are trying to present it as good news, and patients are receiving it actually as bad news. So here's an example. The caregiver says, and it doesn't get revealed right away. In this case, the caregiver had to ask the oncologist for the results. We're not going to know what the X-rays show. I saw it. It doesn't look any different. So you don't see that alignment. You see different conversational behaviors on behalf of both the oncologist and the patient. And then oncologists also deliver bad news. And bad news is very interesting in that there are different phenomena that happen. One that I will draw your attention to is there's what we call an upgrading. Sometimes the oncologist will turn bad news into good news. And here's an example of that. So the physician says, unfortunately, I think that this chemo that you've been on has probably done as much as it's going to do. We're not seeing any further improvement in the chest. And in fact, we're seeing some new areas of disease in the liver that have come up since the last scan. So I think that tells us you've probably gotten as much benefit as we're going to get from this treatment. The good news is that there's a lot of other options here. Okay, we have a lot of other chemotherapy options available to us. So you can see the oncologists we have a really hard job, and I'm confident that you have a really hard job as well. You have to tell people things that they really don't want to hear, that are terrible things that in your normal life you wouldn't do. And yet that's our job. And as an oncologist, you try really hard to do that well, but it's very difficult. And this kind of pattern where you see oncologists kind of upgrading things, and usually the upgrade is around treatment by saying that I have other treatment to offer. So what's happening here is, oncologists oftentimes are seeing their tool, which is chemotherapy, as kind of the answer, and they get boxed in a little bit into talking about that. This particular case, by the way, was a young person, 34-year-old Asian man with lung cancer, who had multiple prior lines of therapy, and the options that were on the table had about an 8% chance of working. And so even here you can see the oncologist wanting something that was good, but even calling something, there are a lot of other options here. when the reality is actually there were few options and they weren't particularly effective. And for this particular patient, actually, who went on to develop brain metastases, which is one of the reasons I thought this case would be interesting for you, he dies actually just a month after this conversation from brain metastases. So we hypothesized and wrote a paper about a possible intervention. So here's my first designed conversation intervention to present to you. And it is very simply a question. And so this actually, I think, applies to neurosurgery as well. So in oncology, we talk about symptoms and then scans and then treatment. But if you put in a question after you've discussed results, so I think this is would apply to you. So you present results, whether it's an MRI or a CAT scan or labs or whatever the results are. After you present the results, you ask a question. Would you like to talk about what that means? What's very interesting is that patients usually give you a very strong affirmative response, and often they give you a double yes response. So, would you like to talk about what that means? Yes, I really would. Yes. No one's telling me what's going on. You commonly get a double affirmative response. And what we observe, I'm going to show you a transcript now. What we observe is that this single question dramatically remodels the oncology conversation. Here's an example from a real transcript. So did Dr. Jones or others talk about what it means that the cancer went from lung to the bone? Is that something you want to talk about? That I'd like to learn as much as possible. I'd just as soon you be as straight with me as you can. So there's your 2 yeses. Okay, in some of the things you're saying, it makes me suspect that it isn't news, but what it means is when a cancer spreads from one place to another place through the bloodstream, to the best of our knowledge, we might be able to control it or maybe help find more time, but not make it go away. Right, I understood that. Okay, so it means that it's incurable. It means that because you're otherwise well, this is the thing that threatens your life. That's really what it means. So we didn't see anything like this in the transcripts without this intervention. And just this simple question and the patient asking for honesty and more information appears to unlock the oncologists to do actually a really pretty darn amazing job at talking about things. So a very simple, I try to design very simple interventions that are not necessarily easy. I mean, asking this question is not easy because it invites a dialogue around prognostic significance, and that's an uncomfortable topic. So just asking this question, actually, some of the feedback that we get from oncologists is that's hard. It's scary, some say. It's true, it is scary, but perhaps that's why we didn't in our initial transcript see any real prognostic discussion. Perhaps this is one of the reasons why oncology patients report a limited understanding of the curability of their disease. It's because this is really hard to do. And this question helps make it easier because you get alignment, this strong alignment from the patient, which creates what you need to be able to engage them. So I would like to ask you to imagine yourselves presenting an MRI result, whatever it might be, and then asking them, would you want to talk about what that means? And seeing what happens, seeing if you feel that unlocking occur in yourself to talk about the prognostic significance of the findings. This is another tool. So headlines and supporting evidence. Typically in medicine, we do supporting evidence. So we do the subjective, the objective, the data, and then the assessment and plan, right? So the way in which we think is we build our case and then we provide our assessment. The reality is that the rest of humanity does it the other way around. They use a headline and then provide the supporting evidence. So think of a newspaper, right? The newspaper gives you a headline and then you can decide, do I want to read that article? Maybe it gives you a subhead and then you give lots of information and you can either read some of it or all of it. And the reason why this is important is it works much better when you're talking with patients if you can figure out what the headline is and then the supporting evidence, as opposed to the way we typically do it. So we have lots of transcripts of surgeons, actually, not neurosurgeons, but acute care surgeons talking to patients. And you very commonly see them present information to patients in these shared decision-making conversations in the way we doctors typically think. So, they'll talk about the CAT scan and the evidence that they saw. They'll talk about the complexity of the surgery that might need to be performed. And then at the end, they raise the issue of whether or not surgery should happen, that sort of thing. It's a very challenging exercise. Actually, it's one of the things that for palliative care fellows early in the fellowship, we work a lot on, and they need a lot of practice. It's actually not hard to, it's not easy, rather, it's hard to change the way you present information. You have to go from hearing from a resident and flip it around the other way. But I can tell you that from a patient perspective, it's dramatically easier for them to understand and grasp. So very simple, this is another design element, which is take your headline and put it up front. And that requires that you think to yourself, okay, for example, with my fellows, I'm always asking them, what's your headline? What's your headline? All right. And then we weigh that out. And what's really interesting is much like a newspaper article, when the headline comes first, you may not need to present as much supporting evidence. Was there a question? Okay. So I'm going to turn to urgent or emergent treatment decision-making and our best case, worst case communication tool. This is work that I've done in close collaboration with Gretchen Shorzy from the Division of Vascular Surgery in the Department of Surgery, as well as numerous others. So just so that we're on the same page, when we're talking about shared decision-making, what I mean is that both clinician and patient have information which is unique. So as clinicians, we know about disease, tests, treatments. Patients know about their body, about their life circumstances, about their goals, their values. And a shared decision-making conversation merely means that there is exchange of information between these two parties, that there's a deliberation that occurs, and that there's a consideration of these values, these goals, the benefits and consequences, and then there's a consensus decision-making process. So not all conversations require shared decision-making. Not all decisions require shared decision-making. Only really actually important ones that matter, need shared decision-making. So I'm not talking about every conversation, nor even every decision-making conversation. The best case, worst case tool looks like this. It's a blank piece of paper on which you have presented two options. In this case, we have total colectomy and comfort care. You present in story form a range of descriptions about the possible outcomes of these two options. We talk about dealing with uncertainty, and the way in which we deal with uncertainty is by using best case and worst case. Now, this is probably something that's quite familiar to you. The difference between the way we use best case, worst case, and this language, and the reason why we call this a communication tool is because we've kind of formalized it and also have this pen and paper diagram that you create, that you give to the patient afterwards, that when you put all of that together, it becomes a more powerful communication tool. But it's designed to help you express uncertainty by using this language. What you do is you create a story. So for example, in our model case, we have a patient who is facing the need for a colectomy, but he has mobility issues. And we think that the likelihood that he survives the surgery is small. It allows us to take what we know about mortality statistics. For example, because of his underlying comorbidities, he has a 70% chance for 1-year mortality. And we can put that into the decision tool in a way that helps patients and families understand. We also ask them a question to encourage deliberation, which is something like, what's important to you now? Or how are you thinking about this, to get at that deliberative process? And then ultimately it results obviously in a decision. So best case, worst case is a tool that we've designed and published numerous times. And actually it's been quite gratifying because now other researchers at other institutions have picked it up and have published on it. And it's certainly the most developed of our designed conversations. One of the things that I love about it is it's pretty easy to see someone who is earlier in their understanding of how to use the tool versus someone who's in the middle versus someone who's advanced. We see different behaviors and different utilizations. I've just a couple examples here for, when we're first teaching people to use it, the best case and the worst case, the star and the box are on the same height. But one thing you notice pretty quickly is people adapt the tool and they start to pull the box and the star closer together when the uncertainty is less. So that's a middle skill that we see. And there are numerous other examples of behaviors that we see people become more skilled with the tool, which is fun. So how do our surgeons feel about it? They report that it's easy to use, 9 out of 10 to 10 out of 10. That is better. I don't know if someone could mute, maybe, but it's better than usual care. Interestingly, about a third of them report that it saves time, although truthfully, that was never one of our goals. And one of the things that's really wonderful is that 6 months after we had trained the acute care surgeons to use the tool, about 8 out of 10 reported that they were still using it, which was great. How do the patients think about it? And they say things like, these are interviews conducted with patients a few months after their surgical decision. Well, then you're on to the whole denial thing of what's happening, So when you have it in black and white on a piece of paper, you can re-reference it when you're more able to take in the information. It actually helps me now when I'm with my dad at his doctor's appointments to ask more questions when I'm there. If anything, I kind of think sometimes the doctor's office could use something like this. We scored these on what's called the option scale, which you use transcripts and it encodes a number of shared decision-making elements. So I can tell you that in a statistically significant way, best case, worst case improves the quality of the decision-making conversation significantly. All right, I'm going to move on from best case, worst case to clinical trial decision-making. This is my most recent study. We actually just finished a few months ago. Well, I'll show you the data in a moment, but I did it in the cancer clinic. Cancer treatment conversations have, as I was telling you earlier, have a really reliable structure. So they talk about news, and then when they talk about treatment options, they have 3. One is a standard of care option, one is a clinical trial option, and one is a quote unquote no treatment option or a best supportive care alone option. They always have measures of efficacy in there. So commonly it might be overall survival or it might be response rates, things like that. They do encourage deliberation and they make recommendations. So these are the elements that are present in a typical treatment clinical trial decision-making conversation in the cancer clinic. This is the option 5 scale, so it includes these 5 elements: context, choice, describing the options, then eliciting preferences and recommendations. My tool most clearly fits in these spaces, representing choices and describing those options. And then by extension, we do get to eliciting preferences and making recommendations. But the pen and paper diagram looks like this. It's quite simple. It's got the word options on it. That's really important. Just telling people that they have a choice is a communication intervention in and of itself. And then the pen and paper diagram that goes along with it looks like this. And much like best case, worst case, the pen and paper diagram and the verbal conversation have discrete purposes, whereas the verbal conversation is mostly about me and the patient together having this conversation. The pen and paper diagram acknowledges that they are probably going to talk about this with other people after I've left the room. So going way back to the beginning when I said I wanted to try to pay attention to the spaces in between my visits, that I have, only 4 hours with a patient in that one example, but there are many more hours that they're thinking about this. And I want to be present in those other hours. And the way in which I can represent myself is by giving them something that's of value that helps to guide those conversations. So my pen and paper diagrams that I have doctors create take time. They take time to create them, but that time is absolutely valuable, and it's an intentional and explicit manipulation of the spaces in between. These tools, best case, worst case, for example, all of the patients on our study still had the diagram. We didn't ask them to keep it, but we went to interview them at their homes and they could all reproduce it. They all had it. When you think about all the paper that people are given just as a consequence of clinical care, they knew exactly where that document was and they said it was very helpful. We know that people take pictures of it and text it to family and friends. So we know people use this document to guide conversation, and that's why we have people spend time to make it. So trial talk looks like this. You've got whatever news you're delivering is on the left-hand side. In cancer care, you've got these 3 options that are quite typical. So you've got 3 options there. And then you're describing them a little bit more and telling a story about how their life will be impacted with each of these options. And then finally, you're talking about some measure of efficacy. In cancer care, oftentimes it's shrinking cancer, but there are many efficacy measures that they use. Here's just a couple of tools from the study. Just a couple of examples, just so that you can see oncologists are working really hard and they're making the tool. We trained the oncologist for 2 hours plus a 30-minute follow-up that happened a week or 2 later. And after 2 hours of training, they were capable of making decent tools, not perfect, but decent enough that it would work. I think the reason they were able to do this is there's nothing new in these conversations. I didn't add any new elements. I didn't ask them to do anything they weren't already doing. We just organized the conversation for them in a way that would facilitate good decision making. Here's some of our results. So we had 330 total conversations that we were able to include in the analysis. A smaller number of those conversations resulted in the patient agreeing to meet with a clinical trial coordinator. So one thing that was interesting is in the intervention group, we had 91 conversations, and in the control group, we had 164. And 92% of patients who agreed to meet with a clinical trial coordinator went on to sign consent versus 83. That was statistically significant. We can talk about some of the limitations of how we had to set up this trial, because 92% and 83% are really high numbers in both groups. But it's interesting that patients were more likely to sign consent if they were presented their options using the tool. We heard from clinical trial coordinators that patients, they noticed that patients better understood their options when presented with the tool. We have some focus group data that I'm not going to show you that is quite unequivocal that patients better understand their options. And interestingly, caregivers who weren't present for the conversation also are able to tell you what their loved one's options are. So the tool is working as designed. Patients like that it's visual. They like that it makes them aware of their options. These are just quotes from patients. We did interviews with patients. So, it has treatments after surgery, and there's 3 different options. They like that it's easy to understand, that it's accessible, and that it was easy for them to compare options. Oncologists likes that it helps them prepare for the conversation. It makes you really come in more prepared, I think, that way. Yeah. They like that it improves the decision-making process for patients. I do think it facilitates a patient's decision-making process. It has helped me facilitate the decision-making process of which approach to take. And it's separate from the concept of consent, right? And using language about side effects and things like that. So that's working as designed. It helps them convey treatment options. The concept that there's autonomy, and then the first option really, I think, is to convey autonomy, and that chemotherapy is not something you're obliged to do. I take good care of you no matter what, right? That part's important. So oncologists are finding their way to talk about best supportive care alone, for example. It helps them talk to each other because the pen and paper diagram communicates to other providers as well. Interestingly, we didn't hypothesize that it would save people time. In fact, we thought it would regress to the mean. Some oncologists take decision-making really quickly and they say, you should do chemo. We hypothesized that it would slow them down, but we hypothesized that others, it might speed them up because they were pretty struggling with these conversations. And we have quotes from both sides, some which said it saves them time and some which said it was time consuming. I want to talk to you briefly, I'm almost done. I want to talk to you briefly about a strategy for making recommendations. And I'll use the example of introducing hospice. You could use it as introducing end-of-life care. There are 2 naturally occurring methods. The first is to say it's time for end-of-life care and here are the benefits, or it's time for hospice and here are the benefits. The other way is to flip those around to say hospice has, or to say rather, I think it's time for us to support you more in the home, to send nursing visits and social work visits and any equipment that you might need. That's called hospice. So one way is to say hospice and then describe it. The other way is to describe it and then say hospice. The third, which I think is the redesign, is to describe the benefits, wait, and gain agreement. This is the conversational aspect. Does that sound like something that's important to you? Yeah? Okay, great. That's called hospice. So the redesign for introducing end-of-life care is talking to people about merits that you've identified as things that would be important to them, getting agreement on that, and then you name it. It actually works far better than saying the word hospice first or end-of-life care first, because that's pretty easy to say, oh no, I'm not ready for that. I don't want that. But if we have just agreed on the merits of something and we recognize that we're on the same page, and then I give you the name for that thing, people are much more likely to continue to stick with you in that space. So I've got some other tools. We've written some papers about, little things like that one whole paper on a simple question, like, would you like to talk about what that means? Or we have a whole other paper on the word want and how people use the word want in critical care family meetings. And we wrote a paper about using words like think, say, or tell instead of want. So there's lots of space for this. It's kind of fun. I have had a great time studying conversations. I'm very curious about what sorts of conversations you have and what sorts of conversations you see as being ripe for design. And that's what I've got.
Toby, that was great. This is Stan. I would say just watching that, it made me think. In spine surgery, we're not necessarily always dealing with life and death situations, and the way that the conversations that I'm having are trying to manage expectations about what surgery might help and might not help. I constantly am getting negative and poor reviews for how I provide patients and get them interactive in their care, even though I spend a lot of time in clinic on it. And so I can see how the diagram probably might be a helpful intervention so that they actually have it in their hand and can review it. So just as one example, and yeah, I really definitely appreciate you kind of taking what appears science, talking with people and trying to create some communication science out of it. So it's really good. I don't have a lot of other comments. Does anybody else want to themselves and ask questions or make comments?
Toby, I want to thank you. This is Bob Dempsey. I think that the thing we're striving for that you are studying scientifically is making sure our patients have an understanding of where they are, what their disease is, and that they participate in their care. And I think there's you've given us some very good tools, but I do feel that everybody is different. Everybody learns differently. If you've ever tried to teach two children math, it's entirely different from one to the other. And I think the most important thing that I would add is this empathy to take the moment to decide, are they understanding? If not, I got to go around another way, or I've got to spend some time, or I've got to use your key questions, which were great. This thing about, you want to talk about that now, is to get them involved, empower them to speak up. That's really wonderful. Thank you.
Oh, I completely agree with you, Dr. Dempsey. I would just add that one of the things that I've been actually, it's serendipitous that you're bringing this up now. I've been I'm constantly working on my communication style. So one thing I'm trying to use is that spaces in between. And to your point, people do take in information differently. They learn it differently. They incorporate it differently. And some people need more time. You're exactly right. If you have the luxury of time, it's nice to give them time in between visits. So we call it planting seeds or just asking. I also use the term homework. I'll give people homework. So just in the last couple of weeks, I used to do this telehealth thing has prompted me to revisit some things, but I would used to, when people didn't have really any other good chemotherapy options available to them, all in that one visit, I would say, we're out of treatment options and hospice, all of that stuff. I realized, what, I could give them some time. There's no reason why I couldn't give them 3 days or a week to say, I'm going to go and talk with my colleagues and look for other options. I want you to think about what I've just said, that we're really facing limited options left. And so I've been doing this for the last few weeks over telehealth, and it's remarkably powerful because pretty much in every example, they come back that week later having really done a lot of processing and really ready to continue our dialogue. So I agree with you. I think you're exactly right. I think if you have the luxury of time, you can start to play around with giving them homework to think about and then bringing them back.
For people who have said, gee, can we tape you getting consent? Because we hear you spend some time on it. And my answer is, which event? Because for a big elective life-threatening training, I will go through it 3 different times in 3 different locations on average. And, until they are teaching it back to me and they understand it clearly. If they don't, in emergent cases, you don't have that luxury. But I think that's one reason why they do well, in my opinion, because they wake up saying, this is exactly what I was prepared for. You told me that it would hurt here, not there, things like that. You told me I got to be out of bed tonight. I'm involved in my care. It's great. Thanks once again.
Toby, I just have one more question from the audience, from Andrea. Is it, and this probably has relation because she's a patient nurse practitioner, is it okay to draw things out on a whiteboard and then have them take pictures of it? Does that seem to work as well? Or mechanical?
I would imagine it does. I am so accustomed to, if I know I'm going to be doing a communication tool, I just literally grab a piece of paper out of the printer or a fax machine on my way into the room. I'm better writing with a pen and paper than I am on the whiteboard. But I have definitely written on the whiteboard, and so yeah, I think it could well work.
Okay, all right, appreciate that. Any other questions from anybody else? It's pretty light. I'm sure everybody's paying close attention, of course.
Very much.
All right,
Toby.
thanks, Toby. I really appreciate it. Thank you. Bye-bye.